Как звук включится, скажете? Звук есть, да?
Да, есть.
Hello, dear colleagues. Once again, we are so sorry. Hello. We need to change the screen. My name is Mynzhylky Berdikhojayev. My assistant Raul Maratlo. Today, 1st of March, and the Ramadan month is started. I wish you successful, safe Ramadan month, and for all who fasting, I wish very strong health, and see you at the end of the month and at Ramadan Eid. And today we have patient 64 years old lady with non-ruptured ICA aneurysm on the left side, and there is a small aneurysm on the right side. We changed the YouTube link. At the first link it was some information we deleted, and now it's unnamed content. Patient under local anesthesia, and I think we need to go once again to the right ICA. Just a second. Yes, unfortunately, this time we have only 8 French Neuromax and destination catheters. I will show you the small aneurysm on the right side. It's a covered nose. That's why it's not the question of any treatment. And there is a bigger aneurysm on the left side. Just a second. Just a second. The neuromax is angulated, but if you can see, just a second. Stop. If you can see on the left side, on the right side, there is a small aneurysm in cavernous. But it's microaneurysm, it's a cavernous, that's why we will not touch this aneurysm. We will follow this aneurysm. And now we need to go to the left side. We tried to go with the neuron max itself. I will do it again. Maybe we need to do a roadmap for easier, not the easiest, easier navigation. Let's see how it will go. Okay, it's too close. Oslo. It's close to the right ICA, and when I try to go with the wire, it's a bit problematic. Our operating nurse for today is Madina, and we asked Madina to give a second hydrophilic wire. This is vertebral. subclavian. Okay. The option number 1, we can ask for diagnostic or coronary guiding catheter, 6 French, or I asked for second wire, and we will try to navigate with the wire. It's a subclavian. Yes, it's subclavian. Okay. Okay, let's try again. If it will not succeed, then we can take a subclavian. We need to push a little bit more. It's again subclavian. This is ICA. I don't know the name of this technique, but it's a double wire catheterization, and it's quite effective, and it's a shipping technique. Thanks to René, I'm familiar with this approach with the shipping. René is René Chapeau from Essen, Germany. I'm all the time saying I have 2 teachers. My first teacher in endovascular, Shimon Maimon. He's from Tel Aviv, and my second teacher. Both of them are friends, and thanks to both of them, I can do treatment, endovascular treatment in neuro, and we can spread our knowledge in Kazakhstan, and we are happy. Thanks to René and Shimon Maimon. Yes, also we are studying endovascular from live conferences and conferences, webinars, but in person I learned from René and Shimon. Also I stayed in Jerusalem with my friend Jose Cohen, Argentinian guy. He's my very good friend, and he visited Kazakhstan several times as René and Shimon. Yes, Dr. Maimon is used to visit Kazakhstan for several times, and we studied endovascular in Kazakhstan. He came to Astana, then to Almaty, and we did cases together. First of all, he did cases, and we learned how to use the micro devices. And now we can we may teach our young colleagues how to do it in a correct way. And we can speak Kazakh and Russian, and it's easy to learn from local doctors. And at the time I studied from René and Shimon. Both of them, and Jose also, speaking only English, and I should study English, and it was a little bit complicated for me, and even it's complicated for local doctors, most of them speaking Kazakh and Russian languages. And then we start to spread our knowledge to surrounding countries, our neighbors. Kyrgyzstan first, Tajikistan, now monthly, once a month I'm going to Uzbekistan and doing cases, and also we did several cases together with my friends in Mongolia. Also I did a workshop in Skopje in Macedonia. We did case with my friend, my very good friend Kublai in Istanbul. Yes, and we tried to change our healthcare system. Thanks to all of them. Okay, patient under local anesthesia, we may communicate with her. It's very good. And today we are planning to do, it will be FD treatment. It's also possible to place coils, but from economical reason, I think the FD is indicated. Yes, we need to count amount of money, and there is also another small aneurysm, the second one. It's a patient with multiple aneurysms. Yes, this is echo. Okay, when you plan to do FD treatment, the size of the aneurysm is most of the time not important. The important part is diameter of the artery, and it's very important. Aneurysm size important when it's more than 15 millimeter, when we need to decide about coil or not to coil, or some liquid embolic injection, and about the neck size, and it's important maybe, but most of the time you need to focus on diameter of the artery, mostly proximal to measure the size of the stent. Distal is also important. If there is a big difference between proximal and distal, then you should decide about additional stent in distal part to prevent the fish mouthing. And nowadays it's very important with the DFT technology we have. It's very important. Okay, we have a pipeline shield which is 475. We have Derivo stand 4.5 by 20, 4.5 by 25, and we have Silk Vista. Рауан Маратлы қайсын қоямыз? Derivo. Derivo. Yes, it's also possible to place Leo Plus and another 10 coils, and the price of the treatment will be expensive than placing single FD. We have also Fred stent. Okay, let's place Derivo, Derivo Hill 2, Derivo 2 Hill, 4.520, I think. Yeah? Шейк сколько емес қой? Или 25 тұрыс па? Or 25. We have more 25 than 20. 4,25 Derivo. Нан аласыз? Derivo. Біріншісі. Так, headway 27. Yes, we short from headway 21. That's why we decided to take Derivo. It's going through the 27, and we will take Xeon Blue. For this navigation, it's not needed neuro guide wires. It's from the economical reason. We are using Xeon Blue for many reasons and headway. Efficient hosts. Headway for many reasons. Xeon Blue for many reasons. That's why, for this case, it's useful. No problem. We can use it. Like last version. 15 секунд здесь. I will pre-shape it and Rowan will use heat gun, fin, for 15 seconds to pre-shape the headway 27. It's very important to pass the ophthalmic segment. Okay, and now it's more precise to measure on the AP and lateral. It's more precise than 3D, and when we taking the decision, the final decision on 2D, and it's look like 3D is also accurate, 4.3, but proximal part was nearly 5. Which is also, but on 2D it's less than 5 millimeter, 4.7, 4.5 maybe, but distal is accurate. Okay, let's measure the aneurysm. It was 10, yes, it's nearly 10 millimeter, 11, okay, no problem. Heparin investment. Now I'm asking the anesthesiology nurse to give a heparin 5,000 unit international, and patient was premedicated with Brilinta, which is ticagrelor, but it's not Brilinta, it's a local one, which is Triventin. It's made by company, pharmacology company in Almaty. We tested million times, and it's effective as Brilinta, the same effectiveness, the same rate of resistance, which is less than, I think it's a 2% of resistance for ticagrelor in Kazakh population. Yes, and usually I'm asking to put two Y connectors. In the case of coiling or balloon angioplasty, it's very useful. Қорқпай жата беріңіз, қазір стенд қоямыз, жарайды ма? Аға, ларноксикам жасайсаңызшы. 16 миллиграмм. I'm asking for painkillers, which is lornoxicam. It's also the local generic. I think it's a local generic. Қай жақта шығады лорноксикам? Лорноксикам қайда шығады? Till now it's Larnado. Okay. It's also generic. AP and lateral, we can see nicely the PCOM, and we can open the stent proximal to PCOM, and it will be safe distance to the neck of the aneurysm. Headway dash events. Stent dash deriva. Okay. We're inside the aneurysm. It's easy to go to the aneurysm. Yes, it's a coronary wire, Xeon Blue. We are using it mostly for the intracranial stenosis cases, but it's also possible to use for other reasons too. Okay, the guiding is falling down. That's why I need to push it a little bit. We may create some spasm. It's not a problem. Okay, then we put another one roadmap, no problem. Okay, it's MCA territory. Now 27 is going to the MCA. Okay, let's check the catheter. Catheter is okay. I don't know why we so hardly push the 27. Нам хавк шкинте, аболесу. До конца идти жирно. Okay. It's very important, first of all, to check for water here, and then need to push it to the microcatheters catheter. Last week we did the Leo baby case, and at the time of pushing Leo baby, I checked for water, but then I forgot to push my stent's hub to the microcatheter, and we lost the stent. We lost the stent inside the Y connector. It's a human factor, and it's possible, and all the time we need to keep in mind about the human factor. I think it's when you do a lot of job, it might be. Okay. Roadmap? Yes, we now changed in most of the places from the regular roadmap to smart mask, and it's good, it's more precise, but there is another problem from this practice. We are increasing the radiation rate, and I think it's technology has a price, and it's a price for this technology. When you do it with the roadmap from angiography. Так, roadmap? Okay, once again roadmap. Yes, now we are at the orifice of PCOM. It might shrink, but I will pull my stent. Okay, I think this distance is more safer. I don't need to cover PCOM segment. It was look like. Okay, just a second. Let's check the PCA territory and timer. Yes, it's very important. When you start to place FD, the timer is important. Okay, let's check. Both PCAs is in place, and but in case of flow diverter stents, it's very important to have collaterals. And if you have PCOM, if you have ACOM, patient in more safe condition. Then when patient has no communicating arteries, then it's risky. Okay, now we open the stent, which is Deriva 4.525. Okay, I try to push as much as possible. Okay. Let's do the angio. Yes, it's a good, nice stagnation. We placed the rivo proximal to PICOM. We didn't cover PICOM. It's very important. Ophthalmic artery is in the segment of FD. Yes, there is published some risks of ophthalmic coverage. I think we can check, but in the first images, but there is no ophthalmic artery here. There is no big ophthalmic artery here. Just a second. We can do it like this, and we can do it like this. There is ophthalmic artery. It's going from upper part. Now we can see the retinal artery. Yes, it's a nice stagnation. It's a meaning of FD is working very well. Okay, let's do massage. I think it's enough. Then we are very close to the neck of the aneurysm. Huh? Yes, it might be quite close to the neck of the aneurysm. Then we can push it a little bit more. I think this position is safe. Okay. Just a second. Let's do 45-degree angulation to check the. Okay. Yes, there is a nice stagnation inside the aneurysm. Okay. Келесі пациентқа келе берсін. It's 4 minutes. Стентіңіз қойып қойдық, қорықпай жата беріңіз, жақсы ма? Бәрі ойдағыдай қазір. Құдай қаласа бітіреміз. Okay. Stand in a safe position. I will take my Aeromax. Let's start pulsating. That's good. The guiding may cause some spasm. And now we can see more clear view. Yes, we covered the neck of the aneurysm with the rivo. And the rivo is fully opened. And if you notice, this DFT technologies, the stents may shrink a lot, and ophthalmic is in place. Plus reusel. Okay. Yes, it's look like there is a good connection with the meningeal artery. Meningeal artery. Okay. Let's enlarge it like this and enlarge it like this. The brain is in a safe position, and this is ophthalmic artery, and it might be good communication between meningeal artery and ophthalmic. But this is ophthalmic. Okay, let's take a look for the ophthalmic here. Ophthalmic is coming from this segment, from here. It's more clear. Yeah, this is ophthalmic. Yes, it's an ophthalmic artery, and now it's in place and everything is okay. Okay, let's see this stent. Let's look for the stent. And, we can do it like this, and we can do it like this. Just a second. Yes, stent is fully covered this segment, and neck of the aneurysm is start something here. Okay, let's check it. Yes, it's fully covered, the neck region, from here till here. And stent starts here. Okay. I think we can wait for another 8 minutes. Now it's minute number 7. I will do one more intermediate angiography. It's a classic, modified classic thrombo test, when Kazakh thrombo test. When we do angiography on the minute of 7, and then last control at the 15th minute. And now I will ask Roland to do CT control. Acquisition, X-ray, XPR-CT. Okay, 5 second acquisition. Okay, let's wait for the control CT. Қорықпай жата беріңіз, стентіңізді қойып қойдық. Қазір контрольный обследование жасаймыз 8 минутта. И содан кейін бітіреміз, жақсы ма? Басыңыз ауырып жатқан жоқ па? Все, жақсы. Patient is okay. Okay, dear colleagues, the CT is ready. You can see the stent, and brain is normal with no problem. And let's look for the lateral view. And let's play with the contrast. Yes, the stent is opened and everything is okay. This is the Revo Hill 4.5/25. Okay. Now let's wait for another 4 minutes and then we can finish the case. The colleagues, we measured the length of the stent. It's nearly 24.3, proximal is 4.4 and distal 4 millimeter. And Rawan made a last control, and I hope you can agree. Aneurysm is occluded. Aneurysm segment is covered with the stent, and now we can finish the case. The stagnation at the beginning and the stagnation now is quite different, but I think it's need time, and it will be slowly and better and better. Okay, let's see this view. It's maybe we need to place one more stent, huh? What do you think? It's not covering this segment, but on this image it's covering. It's all the time dilemma to place one more stent or wait. That's 4.4. 4.9. The option number 2, we can place option number 2, we can place Leo stent inside the revolve. It's a plan B. Plan A, leave it everything like this. You can leave it everything like this. Yes, it's a nice stagnation. This is the neck of the aneurysm. On AP view, you can see the neck of the aneurysm is covered. This is aneurysm, and the neck is here, and it's covered with the stent. It's an inner diameter, and now I will change a little bit angulation to check the neck coverage with the stent. Okay, it's an inflow zone. Раван, осы проекцияда жасап жүрш, 72 налево, каудальный 14. Yes, we need to be sure 100% everything is okay. Краниальный 14 бересің. Жоқ, 72, 18 қойды. 108 бересің направо. This we need to angulate from the right side. I ask to go for plus 18, it will be 108. 108. Направо. with the lateral arm and go 1/3 craniально. It's a caudal on 3D, but it's a left side and then right side cranial 14. Все, Булат. Ага, жасай бер. Okay. Let's check. Екі рет зум бере сал. Бір рет бере сал. Yes, it looks like the neck is covered with the lateral. Danger 108, 14. The lateral is more informative, and you can see on lateral the neck is fully covered with the stent. It's at the inner diameter, inner curve of the ICA, and this situation is more safe and we can finish the case. Okay, see you in the next 20 minutes. Next case, case number 2. It's a meningioma case. Yes, қалайсыз?
Нормально.
Жақсы ма? Сол аяғыңыз қимылдап көріңізші, оң аяғыңыз қимылдап көріңіз, оң жағын. Қолдарыңыз қимылдап жатыр ғой. Yes, patient is okay. Now we can finish the case. See you in 20 minutes. Okay.